So I was really interested to know, you had recently posted on Instagram about the postpartum return to run test or protocol. And I
Yeah.
was interested to hear about that because a couple of people close to me who have just had babies, I was kind of like
Mm,
wondering, when can they run? When can they get back to the gym?
yeah.
Where did this whole thing start?
Yeah. So it's really interesting. So just to give you some perspective, the UK postpartum return to run guidelines that was published, Tom Goom, Emma Brockwell, and Grania Donnelly, and basically pulled together whatever data is out there having to do with female running postpartum. And you're not at that point in time, there wasn't really anything. And so the nice thing about that, that was kind of the beginning of us starting to realize that like the world is a smaller place. So I want to say, I always screw up his last name, Blaze something or other. He was at Nike, he was at like UVA or something like that, had come up with like a 5 step, like just return to run screen just for orthopedics. And that's where a lot of this stuff comes from, is because we didn't have anything. And so what people forget is those are guidelines. It's not anything that was ever peer reviewed published. It's out there. I think there was an infographic in BJSM. But I think a lot of this is just based upon, okay, what do we generally know? And it's been, it's 2025 now. We've been playing around with it for a long time, but we had to have a place to start. Um, and that was the first opportunity we had to have some sort of framework to say, hey, maybe we should look at something to see if you're ready. So, for perspective, I had my son was born in 2011. My daughter was born in 2013. And so I had all these ideas of, oh, I'm going to run through pregnancy. I'm going to run right into the delivery room. Yeah, I had no way to actually know if that were going to happen or not. I was also 2 years off of hip labral surgery and FAI surgery, which, as you know, back then the rehab for that was kind of, can I swear?
Yeah.
Okay, shit. That's not a big swear word, but it was shit. And so, like back then, they're like, "All right, you never know." It's like, okay, you've got to do an hour of warm up to be able to run pain free, and that was before I had kids. I'm like, I'm not doing that. So, in retrospect, yeah, I had no business running through pregnancy, and as it happened, things got shut down at like 19 weeks anyway because of pain that today I would know how to address. But again, like we had these ideas, yeah, women can do all this stuff. We were trying to shift gears about women participating. So there's also this social parallel that it's okay for women to run in pregnancy. But we had no way to assess how, when, and then you also had a profession that was kind of gatekeeping, like, okay, well, you can only do this if, or you can only do gentle exercises. And so that was kind of sort of the mindset going in, and now we have a baseline to say, okay, well, maybe we can actually sit down and physically assess. And then even since then, I think just having the awareness that we have, such a broad expanse of what running in pregnancy and postpartum can look like. So recently on my podcast, Active Mom, I just talked to, she's an ultra runner, Sophie Carter, that she actually took her Garmin data and shared it with a lab in Alberta with Margie Davenport, and she ran and raced ultras during her third pregnancy, which was twin, and her fourth pregnancy, which was singleton. And how fast she ran in her third trimester of her fourth pregnancy, I can't do on a good day ever, like well, ever in my life. And so we have this broad expanse of, we have these people that are phenomenal genetically, physically, all these other things. And then we also have people that, they have a lot of issues. How do we kind of navigate this? But what we're starting to realize is, I think having those guidelines, it gave us a place to have a mutual conversation and a place to start. I have since played with it and adapted it, and I think that's what a lot of other people have done too. It's a great starting point, but by no means is it a blank check to be like, hey, if you take this at 6 weeks, you're good to go. I sometimes give it at 2 to 3 weeks. I sometimes wait to give it later. I have moms that maybe they don't get back to running until 2 to 3 years after. I have moms that maybe get back to running when they're perimenopausal, and I give it then. So um, it's a tool. It's not written in stone. It informs all the rest of the stuff that we look at and do.
Are you seeing that there are moms who are able to, I guess, quote unquote, return to sport if they had an easier pregnancy? Or are you also finding women, mothers who had easy pregnancies and the postpartum period is way more challenging than they otherwise would have expected?
Both. And I think that's what makes this a very challenging conversation, is because there is no guarantee that because you are active in pregnancy that you're automatically going to have an easy way back, because you have that whole delivery thing in the middle. And there's a little bit of parenting advice kind of thrown in here too, is the second you conceive is the second you start to, relinquish control. Um, you cannot control necessarily, how that delivery is going to go, how that pregnancy is going to go. Are you going to be throwing up for, 9 months? Are you going to have issues that are musculoskeletal that are related to your genetics? Like we don't, there's a lot of these things that we can't control. What we do know, and we have more and more data that's pointing to this, is if you are active in some way, shape, or form, it is good for you. It is good for the fetus. We have more permission now with studies to say, yeah, you can totally weight lift. You can bench press on your back and you're not going to kill your baby. Like, yay, that's good, because that's a thing. And I think that's the hard part, is you have this conveyor belt and people get on, they get pregnant, and then they get off, but the information doesn't go back. And so these old wives' tales of, oh, you can't do this, you can't do that. And the hard part is, I can tell you that as a provider, I can tell you that having read the evidence, but I can also tell you that sitting there as a first time pregnant mom, or even a second time or third time mom who I've had a miscarriage, you're second guessing everything. So there's no promises. So you kind of have to go in, lay out the information, be like, all right, what's best for me right at this time? And the advice that we're giving is more, instead of, I have to bestow this permission upon you that you can go do this, is, hey, how are you feeling? What's your current activity level? How does that feel? Are you experiencing leakage, pressure, pain? Are you getting sleep? Is your baby getting sleep? Are you getting nutrition? Do you have any risk factors for low energy availability? Are there any other things that would make us be concerned if you did start back early? Do you know what these red flags are? Let's keep talking. Because I think the pendulum swang to, we were going to kind of shut this down, and control every little bit of it. And of course, physios love doing that, to, gosh, maybe you don't need me for everything. Let me be there to support and guide you instead of being a gatekeeper.
Did you take a lot of, because it sounds like you're a pretty early adopter of having
Mm-hmm.
these very necessary conversations, which are also difficult conversations to have because they're so highly individual. Did you take a bit of heat, and do you still take a bit of heat? Because like I saw a mother, she was about to pop in the gym 2 weeks ago on the treadmill walking, and she was just holding on to like the handrails on the treadmill walking. And my girlfriend, who is a PA in the NICU, so she specializes in like, let's deliver your baby and keep that premature baby alive. And she looked, she goes, "Hey, you see that woman? How many weeks pregnant do you think she is?" And I was like, "I don't know, 35." She's like, "Yeah, probably around that. She's ready to pop in the next couple of weeks." And I was
Mm-hmm.
like, "How safe is that?" And she's like, "No, everything looks good if she's being careful
Yeah.
about it." And she had very strong like legs, strong calves, strong quads. And I was like, she did her homework before these 9 months.
Mm-hmm. Yeah.
And I'm kind of wondering, I'm
Yep.
like, what then happens after, assuming she has like a pretty good delivery?
Yeah, I mean, again, I think you have to step back and look at the societal parallels. So, for a woman to even be pregnant on a treadmill, that wasn't happening back when I was a kid. I mean, if I look back at my mom was an early adopter of being more active in her perimenopausal years. She would go into work and go swim and go work out and that sort of thing. But she wasn't an exerciser when I was home. This is after I had moved out. So when you don't have societal expectations of women being active, and that's your starting point, that's one thing. Then we started to have women being able to do marathons, and then, be okay there, be in the gym. And I mean, let's just talk about CrossFit. Like, for women to show up and lift weights, that's the first part. Well, eventually women potentially are going to get pregnant. Is it okay for them to be there? And so I think there was a lot more acceptance of those things in those communities before the medical profession. Because let's just be honest, how much do OBGYNs know, the average ones, about exercise? They don't. Now, I will tell you that there's OBGYNs who are ultra runners and exercisers and things like that. But that's, again, pulling in that personal experience to be able to say, yeah, I did this, this is possible, and so on. Um, do people still get shit? Yeah, absolutely. Especially online when people like to judge or whatever. But again, like there's no promise that and I think this is such a hard thing to tell somebody. I talk about the portal that you walk through once you have your baby is I can tell you all these things and you're going to hear it one way. And then as soon as you walk through that portal, all of a sudden, everything that I just said is going to mean something completely different. That's not anything I learned in PT school or anything as a provider. That's something that I learned as a mom. I'm like, oh shit, that's what you meant because nobody you're like that's not going to happen to me. It's going to be I had the worst, I had the worst uh delivery situation with my son. It was a 3-day induction. I both my kids went to 41 and a half weeks. I got to push with him. He was not recovering, ended up in a C-section that I had not thought about or planned for. And so that kind of screws with your confidence a little bit too. Is like, gosh, if I can't do this, then what does that mean? And then to not have a good idea of how to rehab back from that when basically you've been gutted like a fish and you have no abs because basically your entire profession is like, don't do this or you might have your abs split, right? There's so many different things to kind of have to navigate is like, what are the expectations moms are walking in with? What are their expectations coming out? You have people that are very, very fearful of exercise. You also have people that are overly obsessed with exercise and that's their identity. And then how do you meet them where they are? And then how do you set up expectations knowing that there's things that we can anticipate and things that we can't?
Well, it's interesting because I was speaking with a couple of different concussion researchers recently.
Mm-hmm.
A couple of whom I went to school with, like grad school, and then a couple like I just kind of got in contact with.
Oh,
And I was like, all right, because I'm not a concussion person, I understand to a small degree. What's the return to sport look like? Especially like I watch the NFL. I love the Philadelphia Eagles. And if, Jalen Hurts gets dinged, they're like, get him in the tent, get him out of the tent. And I'm like, well, I guess if he's making $20 million a season, like that's the risk he's going to take if he has CTE at 40. All right, that's up to you, man. But they were saying with like concussion, it sounds like very similar to what you're saying is that there was not necessarily a protocol with respect to what do you do postpartum? And like now they're kind of just playing with these tiny independent variables and saying, this works, this might not work, this works, this might not work. But big picture zoom out, everyone's going to be a little bit different. So it's
yeah.
hard to say like this is the
Yeah.
best thing to do.
Well, I mean, and this is where, I love having conversations with the researchers is because at least the ones, there's also ones too that are researchers, but also have their toe in the clinic. And so that's where I think frameworks work really well is because you kind of have phases, which is similar to like return to sport after injury or something like that. Is initially you just have that foundational, let's just start moving. And I like the fact that these frameworks don't have dates and don't have this, this phase has to be this long. There are, and this is again, there's a lot of reasons why research in this area is incredibly challenging. One, the ethics involved and pregnancy and so on. But also, I think because there's so many variables, not only for mom, but for the baby. Like my oldest did not sleep the first 5 years of his life. Did that impact how easy it was for me to get out of the house? Hell yeah. Like, so like, how do you quantify that? And so, I think it's nice that we have freedom and flexibility to kind of take these phases of, okay, initially we're going to have foundational movement, then we're, just walking or things like that. Then we're going to try and, do a screening. I'm like, okay, do we need to dial into any deficits specifically, or were there any, issues that you had prior to pregnancy that we need to be aware of, with me, with my hip? Yeah, of course, there's going to be something, filtered off from that. And then regular activity. And then sometimes it ends there. And then you have some people that want to compete. Or maybe they just want to do a turkey trot with their family, or the fun thing with first time moms is we all feel like we have to prove that we are who we are, even though we're really actually just better. But we want to get out and say, we can still do it. We can still be active. And so what does that look like? Does that mean turkey trot? Or does that mean you're going to try and bang out a marathon in 7 months? Like that can look a lot of different ways. And then we also have our professionals that this is their day job. And so there's such, again, like, that's why I think a framework works really nicely is because you can put it across a lot of contexts, but you can also take it and jump it forward to women who are my vintage that maybe have not worked out and haven't had that time where we're solely focused on their kids. Now they're diving into perimenopause and like, gosh, I didn't really do pelvic floor PT because that wasn't a thing. I'm having issues because the hormones have kicked in. I want to get back to exercise. What does that look like? So a framework works really nice, kind of across those different genres.
That was one other thing I wanted to touch on. I think that's like a good
Yeah.
deviation point there, was like speaking specifically about the pelvic floor. Because like
Mm-hmm.
I was interested in knowing like I have a good family friend who just delivered her fourth healthy baby in
Mm-hmm.
5 years.
Yep.
And the next day she was just pacing around the hospital room, like just waiting to be discharged with the healthy baby. And I was like, holy crap. I mean, she's 34, 35. So like decent age. She's strong. She's just one of the most type A people you ever meet. And I was like, well, what constitutes that? And then when I volunteered in the hospital and you have someone who's just
Oh
like
yeah.
crippled over in pain, and what is that sort of thing, and how much of that could be soft tissue? You had brought up musculoskeletal. Obviously,
Mm-hmm.
there's the crazy hormonal imbalances that
Mm-hmm.
go on with like the depression piece of it. But I'm trying to figure out this avatar of like fourth baby in 5 years, and she's like, "Yep, I'm ready to drive home." We're like, "No, no, no, you're not driving home. Like your husband's going to drive you home, and you'll be in the back with the
Yeah.
kid."
Yeah. No, again, there's so many. So just to give you perspective, here in DC, we have a lot of women that would fall into the geriatric pregnancy, so basically over 35. So my average new mom is between 38 and 42. So that's pretty average for me here. If I have a new mom that's in her 20s, gosh, I barely know what to do with her. Um, but it's that experience that you go through with delivery can look so many different ways. Um, there are women that, let's just be honest, are genetically blessed to have easy pregnancies and easy deliveries. What I will tell you is women that laminate their birth plan, and I can say this because I did, don't laugh. Usually it doesn't follow the birth plan. The more rigid you are, the more likely things are going to go awry because that's just not how that works. Um, but I mean, just to give you a broad variety, you can have somebody go in and have a first time vaginal deliveries. I think the data points to that's where, if there's going to be a birth injury, that's where it's most likely to happen. I think people stereotypically tend to think of perineal laceration, so tearing between the perineum or that open, or I'm sorry, the vaginal opening. There's a space between it called the perineum, so tearing of that tissue back towards the rectum. And if you have a pretty big tear, that can be very obviously, a birth injury. We can have tearing of fascia, ligaments, avulsions, partial avulsions, in a three-dimensional way, all up through the pelvis. And I think that's more of a new understanding for physios. I think we're getting more people that are doing like 3D modeling of what all this stuff looks like, and understanding that pelvic floor dysfunction or pelvic floor symptoms or pelvic symptoms in postpartum can be more than just the pelvic floor itself. So historically, we've been focused on strength, 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 from I think the 1940s with whatever Dr. Kegel. Um, what we understand from the literature now is so many more of our issues like stress urinary incontinence, urgency, frequency. A lot of that is actually much more related to muscle coordination. And that's where it's such an interesting dichotomy between navigating these issues and like MSK, because it's almost like MSK didn't want to own pelvic floor because it was down there, and pelvic floor didn't know anything about muscles because it was all like vagina and reproductive organs. So that's how I was trained. I was trained in two incredibly separate pathways. And my background is orthopedics first. And so it was really annoying that I had these two separate pathways. And one day I'm just like, dude, we're just going to mash this up. And realizing years later that other people felt the same way. And so that's kind of how we treat it now, which we lovingly call holistically. And I'm just like, this is just what I do. But when you realize, oh gosh, a muscle can do more than be strong or weak, it's like, come on. MSK people have been known this for a long time. And so Then when you pull sport into it, and we're starting to get some more data looking at, and this is the hard thing too, is like, how do you measure what the muscle is doing? And how do you explain why you think it's doing what it's doing? So for example, when you run, you have an anticipatory activation of those pelvic floor muscles because your brain's like, oh, I've done this before. I need to counter that foot hitting the ground. But then you have a reflexive recoil very quickly after. And that's not even remotely close to the speed of doing a cognitive contraction. But yet for years, we were taught you need to do, you know, quick flicks, which is a second long, and that'll target your fast twitch muscles. I'm like, no, not really. But pelvic floor PTs were only doing pelvic floor stuff. But what we actually needed to be doing was be training load, which might actually mean, hey, we start doing some bouncing, we start doing some impact to actually challenge some of those automatic kind of pathways. But if you don't put those two together and they live in these two silos, you never have that conversation. So we're still catching up with not only what is the pelvic floor doing, how do we measure it? Because how do you're not going to stick needles inside, or you could stick a probe up in, how are you going to run with a probe in? Like there's a whole logistical, like female engineers in STEM are going to save us with this whole thing. We've got to figure out how to measure what we're measuring and then kind of understand that. And then from there be like, okay, now that we kind of understand what normal is, which we still don't know, how do we figure out how some of these pathologies are coming and how much of this is actually architecture and not providing support because of fascia, ligaments, avulsions, things like that, versus this, old-fashioned idea that the pelvic floor is a hammock that holds the organs, that's not at all what it is.
It's funny. We, in my anatomy class that I teach, in the past 2 weeks, went over the lower extremities, and I was talking about the pelvic angle between
Mm-hmm.
males and females. And I was like, well, what do you notice about the shape? What do you notice about the angle? Like, why is it like this? And it's like, I love from like the strength and conditioning standpoint that men and women are pretty much just as strong with the lower half for very good
Mm-hmm.
reason. But a woman's pelvis is going to have a much wider angle conducive
Yep.
to childbirth. And I
Yep.
think if I could, play God, like what would be like the easiest thing? And I could ask you, the expert on this, would the pelvis just need to have much more of a retractable opening, like a bridge, which like actually
Oh,
opens up, or the baby just have to be smaller coming out and then get bigger? Like what's the main issue here? I mean, there's probably
first
a
of all,
lot of issues, but like, does the baby need to
yeah,
get
I
smaller, or does the
mean,
pelvis need to be bigger, stronger, wider?
no, I mean, I think we need to stop playing God ourselves. And so I think we need to recognize, and I think this is where some of the research is going, is when it basically, what do we need to do to prevent birth injuries? And when are we potentially at risk? And I feel like we're at that point clinically where we have women that are coming pre-pregnancy, pregnancy, and we have an ability to say, okay, do you have any potential risk factors? So, for example, I evaluated somebody this week who never any kids prior to pregnancy. She had stress urinary incontinence. So I already think something's up, right? And so we screen through. She doesn't have any symptoms of like pain with sex or constipation, no history of back problems or hip problems or anything like that. I'm like, why does your, potentially we're looking at a high tone pelvic floor. And so I'm like, why does your brain think this is an awesome idea? And why is that going to be something we want to pay attention to? Because ideally, and again, this goes back to a strong pelvic floor is great for delivery. The pelvic floor doesn't push the baby out. The pelvic floor has to get the hell out of the way so that the uterus contractions can work with the baby moving to do that. So if we talk about what's ideal, it's a coordinated pelvic floor. Potentially what are the things that we are, that are doing, or our brain is adopting this strategy of high tone pelvic floor. And again, we don't have data to say, gosh, women have had, tight pelvic floors for a year, or pain with sex or things like that, because we just didn't give a shit. And now we're like, okay, well, maybe these things are going on. Is it possible? And I don't think we're there to be able to say that yet. Is it possible that if I have somebody that understands birth, they understand, and the birth team, they understand, if we can work on relaxing this pelvic floor and setting this up, do we potentially set ourselves up for less likely having an injury? Obviously, I can't control how big my kid's head is, unless you start going back and be like, okay, we're choosing our mate based on head size. We can write a book about that, on questions you should ask before you get pregnant with somebody. But then from there, like, I think there's a lot to be said about where you deliver. Are you a white woman? Are you black and brown? Do you have any other medical risk factors? Like, again, there's so many variables here that we need to take into consideration. Here in DC, we have a lot of women that have kids later in life. They've been able to control everything in their life. Now they want this natural delivery, which I always ask them what that means. I'm like, okay, what are you adamantly against? What are you adamantly for? And they think they can control everything. And I'm like, all right, well, does your provider, are they in support of that? Well, I don't know. I'm like, well, you're not going to be the person to change their mind. So I think there's a lot that we need to talk about medical management as unfortunate as it was that my first delivery ended up in the C-section that I had not prepared for. I am fully aware of the fact that, not that long ago, I would have been dead and my son would have been dead. So I'm cool taking, the route that we took. Happy to be here. And then with my daughter, my kids apparently don't drop. That's a whole other conversation. But like we said, hey, we're going to have this conversation of if it looks like she's not going to drop, I'm fine having another C-section. I did go into labor with her. She wasn't going anywhere, and I wasn't choosing for her to be born on 9/11. So she was not born on 9/11, and we went ahead with a nice, easy, straightforward C-section. Again, I think there's so many things we cannot assume that there's perfect and that we can control those things. And a lot of first time moms go in thinking, well, if I just do X, Y, and Z, and if I exercise right and I eat right and I do all the things and I do my yoga and my all this, then it's going to be perfect. I'm going to go to my OB and they're going to do exactly what I want. And it's just not real. And so that's always a very slow, interesting conversation to figure out how to open people up to the possibilities that can occur and where they can control things and where they can't, which is also parenting advice.
It's that's a really interesting consideration. I just wrote down 4 bullet points,
Mm-hmm.
and one of them was ethnicity, and I wanted to dig into that.
Yeah.
Well, I talked about
Yeah.
another one I talk about with my girlfriend all the time is this idea of hospitals versus midwives,
Mm-hmm.
preeclampsia, because I studied blood pressure in grad school, and then
Yep.
flexibility versus strength and your pelvis. And
Yeah.
one thing that you had brought up, and God, I think this is so interesting, and it's like this, it's a double-edged sword. You had said that a
Mm-hmm.
lot of people who you see around your area have been able to control their environments. And
Mm-hmm.
like currently, the birth rates have been consistently going down in developed nations because like everyone's getting graduate degrees, everyone's doing their side hustles, and women are way more in the workforce than they were, 30, 40, 50 years ago. And it's like you're now having this, you know, um, geriatric pregnancy of someone who's 35, 36, unbelievably successful, type A,
Yep.
picture perfect, good
Yep.
looking wife and husband. And then she's now setting herself up for like a lot of big question marks. And as you said, geriatric pregnancy, even more things which can go wrong. And that just happened for me personally with like a couple of good family friends who I know who are believably, like if you looked at your LinkedIn, you'd be bowing down to their LinkedIn and
Mm-hmm.
then you go, but you're 36 and you want to have a baby, you're gonna have to go with maybe
Mm-hmm.
IVF. We don't know how the
Right.
pregnancy is gonna go.
Right.
Holy cow!
Yeah. Yeah. It's not for the faint of heart. I always joke that like physically we're ready in our 20s, but mentally probably not so much. And then it's a little bit harder in your 30s and 40s physically, but mentally, like, some things are better, maybe some things not so much. No, I mean, that's a struggle. And again, you kind of mentioned earlier about, postpartum depression and things like that. I think that can be a really abrupt change for a lot of people. You've had everything the way that you want, and then all of a sudden your body, you don't recognize your own body, you don't recognize your life. Some people, it's really hard for them to bond with their baby if the birth didn't happen the way that they want. If you've had a trauma filled delivery, how do you navigate that for subsequent pregnancies? Like there's again, it's so multifaceted, and that's where I think I have, having navigated a lot of this stuff, like especially, first birth that did not go as planned, I had to navigate that stuff to be able to get to other ones. And, it's just, there's no right way. You got to be able to recognize that there's so many parts and pieces to this. Um, and we're getting better at helping women get help, identify it. And I think that's one of the hardest things is again, if you've controlled everything your whole life, to know that things come up and you might have to deal with it. And it might not be perfect, and we haven't even talked about, the other side of like, does your baby eat? Does your baby sleep? Does your baby have any sort of, learning disabilities or motor disabilities or things that you hadn't planned on? I mean, and that's the whole stressful side of that. That's completely separate. There's a lot of moms that will put aside their own physical health to solely focus, and their whole identity is on their kid. So yeah, I don't know if I answered your question in there, but
No, and I don't really think I even asked a question. I kind of just put like I put a thought out there because this stuff
yeah.
is like I'm now at that age where like all my friends and their like
Mm-hmm.
husbands and wives are having kids. Like I just turned 30 and I'm like, okay, everyone's having a baby.
Oh God, you're a baby.
But this stuff, man, it freaks me out so much. And like I've been like very open that my goal in life is to have a
Mm-hmm.
family and then to open
Mm-hmm.
up an ice cream shop.
Cool.
Truly what I
Do
want.
it.
I love making ice cream. I make all different flavors
Okay.
and they're getting better, but like I just want to have a family and like that's it. But like
Aren't you sad you went and got that PhD? You're like, I
10
did all that
years.
to just do that. I
10
know,
years.
but you had to go through the one to get to the other. And that's where I just got stupid lucky that my life happens to parallel the work that I'm in and the women that I work with every day. I can relate to, and we can talk about our kids, and it doesn't seem weird and that sort of thing. So I just got lucky. So
Well, you've consistently put in the hard work with everything that you're doing. So I mean, I don't think there's like a ton of luck. I think you also make your own luck.
I I got lucky, but again, like I think it's a choice too. Is that with so many things in kind of when I had my kids, what I was taught as a provider did not hold true, and I had a choice to be like, okay, this is what it is, and then I would have to walk away from things like running and working out that had been a huge part of my life for a very very long time, or I could pivot and say, okay, there's a possibility that there's another way to do this, and it just hasn't, been invented. Or, and again, like I'm not the only one that was realizing this, and this is the coolest thing, as much as we, shit on social media and things like that, to know that there's other like-minded people that were thinking the same thing, that we were in these spaces. We were in pelvic health, we were in orthopedics, we were in sports. There had to be some answers in there. And now to have research groups of women picking this up and running with it and giving us, background and a foundation on stuff that we've been just kind of like guessing at. And, we can have faith in our results, but we still want to know why too. We want to still be able to do better and change the narrative so that the next generation, I mean, I have two kids that I hope that whatever I've had to navigate is going to be completely, different for them. And I hope the foundation that we've built is something that, they can stand on if they choose to have kids. But I can't tell you that that was a conscious, like, I'm aware I'm doing this. This is all in the rear view. You're just like, all right, well, I want to run. So let's figure this out.
Well, I mean, that was I know it was kind of like my big sort of question to you is like, how did you get into this space? And
Yeah.
I feel like it's funny because like doing any sort of thing in healthcare research, usually you go like where there's a need, where there's going to be money, and
Mm-hmm.
like I think I'm a few years behind you with respect to like even that physical therapy field. But when I was in college between 2013 and 2017, I was like an aide for 2 years, and
Mm-hmm.
all the PTs were like, Mike, don't do this. Like, don't do it, don't do it. And I
Yeah.
didn't get into PT
Yeah.
school, and I was like, it was kind of a blessing in disguise because I had a crappy
Mm-hmm.
GPA, and I ended up going like the master's PhD route. But like all my friends who became PTs who are now like around 30, they're like 150 grand in the hole. They're seeing two
Mm-hmm.
patients per hour, only clearing like
Mm-hmm.
60 a year. And they're like, I am so tired at the end of the day. And I'm like,
Mm-hmm.
yeah, you're never getting
Yeah.
yourself out of that debt. And I'm like, well, what's
No.
the shift that we have to make there?
Oh God, where do we start with that? I mean, first of all, you know, I started. I got really lucky with the 5 year master's straight through, and I had a marketable degree, and that was just a split period of time before the DPT and that sort of thing. Um, we all go into this because we want to help people, right? Well, what does that mean? I wanted to be a neuro PT. I wanted to work with stroke, spinal cord, that sort of thing. Finished PT school. I think, as I mentioned before, it was the drop in the market. Managed care started. There were 60 in my class. 6 of us had jobs when I graduated. Um, my first couple jobs, the people I was working with were basically working as technicians. Um, like the clinic that I worked at in upstate New York, they wanted us to use shortwave diathermy, ultrasound, hot packs, and I feel like there was one other heat modalities on every single patient. When we wouldn't do it, like we had all these aides that were like our mother's age, and they had to let them go because that's the practice was shifting. And we're like, well, we weren't taught that way, but yet we were still almost treating as technicians. And so when I moved to DC to do pelvic health, I didn't know what the heck it was. And it was still in its infancy of, if you are postpartum, you get Kegels. If you have pelvic pain, we'll do trigger points, whatever the hell that is. And people didn't get better. And I hated it. And I was like, I do not, this is dumb. I'm sticking my finger in a hole and you're telling me that this is supposed to work and it's not working. And so I really did not want to do it. And I got hired by a practice that I think she brought me on because she wanted me to build that program. I'm like, I'm not doing it. I picked up a side gig over at Georgetown University Hospital, doing a program for them, which eventually we built into a residency and that sort of thing, and was really, really lucky to be there at a time where we had other people that were like-minded in that. We had an Australian physio that, he brought in dry needling and ultrasound imaging and direct access and imaging orders and all those sorts of things. And one day, like, I'm doing notes and he comes over and he's like, don't take this the wrong way, but I think we think a lot alike. And then he just walked away and I was like, oh, I don't know what that means. Well, he's stupid smart. I call him my annoying little brother, but like, that's smarter than me. To be able to recognize, wow, we can really move this stuff forward. We can mash this stuff up. That to me became exciting. And that to me, where I'm like, okay, there is more. We're on the cusp of this stuff. And, to come from a space where I truly thought that if a doctor wrote an order for shoulder pain, and if that patient did not get better, that's because the doctor knew what to do and I did not. And the doctor knew that I didn't know my ass from the hole in the ground. Like, that's what I really, truly thought. That was such a technician mindset. And I somehow, going into this space where we didn't know anything from Adam and I can mash some things up and have some creativity, that gave me the freedom to be like, hey, I don't know, but let's find out, and surround myself with people that know more about me, more about other things that I can take and bastardize and play with and see if we can move this forward. And that's super fun. Now, throw the debt in there. Like, again, I saved about 2 years. PT school was not as expensive. I know how much college costs now because I've got one heading there in a couple of years. No, I would not recommend anybody go to PT school. You can do what I do in other ways and not spend so much money. But I mean, I think why I stay in this, why I left Georgetown to start my own practice was to have that freedom to help people the way that they deserve to be helped. It took me 18 years being a PT to step out on my own. I'm totally risk averse, which sounds weird because I kind of make all this other stuff up, but like, being confident enough to be, it's okay that I don't know everything, and being okay with, there's a lot to learn and I'm going to make some mistakes and I'm going to learn from every patient. I'm going to do better and I'm going to take my own experience and I'm going to, take that to move things forward. That's the part that's been really cool about it. And to have the flexibility in my practice to be able to see, people virtually or in my clinic in the DC metro area, like any of those things, like that's what makes this all work. And I just got really lucky that I slid in before colleges decided to make bank off of PT students, and PT practices decided to run new grads into the ground to make money. But how do we fix it? Other than fixing healthcare that's currently broken, I think if you are already a PT, I think you got to put yourself around people that that you resonate with, and that it's okay if they're smarter than you and they're probably really nice and they probably have something that you can learn from, even if it's just a sentence or two. Don't ever ask to pick someone's brain. At least offer coffee first. Um, but I think learn as much and invest in other people that, resonate with you, and also listen to people that don't, because you have to understand where everybody else is coming from too, um, to potentially think differently, or also be able to explain, like, okay, that person thinks this, I think that, why is that? Like, you kind of, I feel like critical thinking is lost, and the hard part is there's no dollar sign behind critical thinking right up front. But I will tell you, having, a solo practice for 8+ years, people come to me because I can think, not because I have any magic tools or devices or anything in here, but because of, you know how I approach things. So there is, I guess that's the long game, is there is money in how you think.
There's my dad would always tell me, and it seems like we're on the same, this is the same sort of conversation, is my dad would always tell me, Mike, you're not the smartest one, and that's okay. But you can, what does he say? He's like, but you can tie your shoes and have a conversation at the exact same time. And I was like, he's like,
That's a dad thing to say.
yeah, he's like, but you can,
Yeah.
like, hold a conversation. He's like, you're fine, man. He's like, you're playing sports, dating girls,
Yeah.
like, you're good. And I always
Yeah.
thought about like this idea of situational awareness and
Mm-hmm.
seeing the broader context.
Mm-hmm.
And I have so many students who will come to me and be like, I want to do this. And I'm like,
Mm-hmm.
it's cool if you're saying that as a freshman or a sophomore or like even a grad student. Um, but I always challenge them to like think about 3 to 5 other things and then meet with me. Because
Mm-hmm.
if you kind of say, okay, well, talk to this person in this department or in this department, they're going to suck you into this
Yeah.
funnel. And that could be okay if you want to go to OT,
Right.
PT, speech language pathology, mental health counseling, whatever you want to do within like health science, since we're on that conversation. But I'd say, hey, what about this and this and this and this? And it's like, go ahead and, you know, make your own path. And it's funny because with this podcast that I started this like 2 months ago, basically. And I've had like 60 guests on so far, been chatting with people almost 5 days a week. And one person gave me this one piece of advice, and I went, oh my gosh, if this is the only piece of advice I get from this entire show, it's going to be that one thing. And other than that, I've
Now you got to
had
tell me.
beautiful conversations, like beautiful. And I was like, I want
Yeah.
my students to do that, is just like reach out with people, be very kind and
Mm-hmm.
courteous to not take their
Yeah.
time, but also just think, how do I reverse engineer maybe my perfect life right now or what I think it might be?
Yeah. Well, and again, this goes back to control. Is I can very clearly sit here and look in the rear view and tell you how I got here. There's no way in God's green earth that I could have projected it going forward. But I think that there's certain themes that are there, and I think that's the part too. Like, I knew when I thought I wanted to go into neuro, I wanted to be really good at what I did. Like, I wanted to have board certification, which at the time I thought was like the epitome of, respect and whatever. And that's a separate conversation. Um, but I knew I wanted to be well respected. I wanted to be really good at what I did. And so that content area has changed. But yeah, I feel like, I have professional respect. I have, the respect of my clients and people that want to see me. Like, that is still there, that drive, to want to be better, even though I've been at this 26 years, that hasn't gone away. Like, I don't realize that I will, like, my whole social media algorithm is like stuff related to my work, like stuff I read is all, even if it's like mindfulness, is still going to come into my work. Like, I don't look at it that way, that I'm like super obsessed with work, but I think some people could say that. But like, it's all intermixed. It's not, but yet, you know, it's not calculated either. And so I think it's so hard. Again, I'm sitting here thinking about this now as a mom with two very, very different kids. My son's a freshman in high school, and like, oh my God, you're so different than me. How are we going to figure out what you like? Because you just like video games, So, and then my daughter, who's like, I want to be a vet and do all these things. I'm like, do you really want to be a vet? Like, we don't know. Um, but it's also, I am fully aware. I came from, my dad taught college prep and he was an English teacher. Both my parents were teachers. And you go to school, you get a marketable skill, and that can pay for the things that you enjoy doing, which I don't, in retrospect, like, appreciate it. Thank you. Got super lucky. Um, I think we need to find things that we not only enjoy, but we're good at, but we like that we're good at, that it's sustainable. And that's exactly what I tell people about exercise. They're like, what's the right thing to do? It's the same conversation. It needs to be sustainable. You want to keep doing it. You want to keep coming back to it. Yeah, it's nice if you make some money to pay your bills. So let's definitely talk about that. But the job that I have today wasn't invented when I went to PT school. It wasn't invented 10 years after I was in PT school. It wasn't invented like, and so I think that's the thing too, is it's not when you're a kid and you're like, I'm going to be a firefighter or, a vet or whatever, that what can you make of it, and be aware that it's possible that you can make something that doesn't exist. And that's okay. And you can be a regular, ordinary person that you get good grades, you do okay. That was kind of me, and I'm not like super overachiever. I'm not super obsessed with anything, but like you can kind of carve out something that's sustainable, that you enjoy, that you want to keep doing. And, I'm on the other side of my career now where I'm thinking, okay, when are we going to shut this down? I'm like, can I? I don't know. I got to see what that looks like. So stay tuned for that one.
But I even think now that it's my only foray, I think, into like women's health was when I
Mhm.
was in grad school, and we did a
Yeah.
lot with peri, post menopause. And I saw it from like the R1 institution dissertation, like that sort of thing. And it was brilliant, but man, I got burnout real fast. And it was just cutthroat. Let me see the data. The data sucks. We can't publish
Yep.
this. And I was like, oh, okay.
Right.
Like, but big picture,
Yep.
are we moving the needle in the right direction to help the people who need the help? And for me, it was like my mom, because she, I think at 45, she had cancer, and they blasted her way too many times with way too many chemo drugs. And thank God she's still alive, but she had one or two mini strokes, which caused a lot of vestibular issues, musculoskeletal
Yep.
issues, neurological
Yep.
issues at 45, which is still pretty young.
That's very
And
young.
they
Yeah.
put her into an early menopause, and now at 60, it's good because she's so type A that her and my dad want to do all 50 states and 60
Oh,
countries or something, and they're at like 49
all right.
states. They just got to do Alaska. But I think it helps that she's so type A, but I'm like, they didn't know what they were doing 15 years ago. And that was my foray into this of like, how do I help my mom? And I seek out
Yeah.
people like you who I'm like, okay, what can I
Yeah.
learn here?
So, okay. So, so if you thought, pregnancy postpartum was the Wild West, perimenopause and menopause is like part two. Like, so just for full disclosure, I dove headfirst into perimenopause about 2 years ago. I had been on continuous birth control for about 7 years. I'm not a fan of having my period. That's just me. Blood pressure started to creep up. I'm really good. I go to my GP every year. This was like data from pre-COVID, so we can't blame COVID and gaslight ourselves that, yeah, it's been creeping up. Oral estrogen, it's known to potentially have an impact on blood pressure. I knew this. I was like, all right, well, let's come off and see what happens. Lo and behold, I come off. Nothing happens. A couple months go by, and I'm like, that's really interesting. No period. And also around this time, oh my gosh, I'm not sleeping well and I'm super anxious. I am not an anxious person. Like waking up hot at night. My stupid dog, we had this little 18-pound border terrier, and she lays right here at night. And I'm like, oh, she's so hot. We've had her for 4 years at that point. So in the rear view, I'm like, oh my gosh, those are total perimenopause symptoms, right? And so I have a great GYN. I go to her, and she was wonderful. And menopause hormone therapy, which is, typically some sort of estrogen based patch paired with progesterone if you have a uterus, is typically first line for vasomotor symptoms, which are your hot flashes, night sweats, that sort of thing. And this is like within 2, 3 months. She did some quick blood work, but just to get some sort of baseline, she didn't treat based upon that. And she gives me this, and I go on my way. I'm like, well, that was easy. And like 2 months later, I'm feeling good. And I'm like, did I really experience all those symptoms? Yeah, I did. And I was feeling better. But then lo and behold, about 6 months after that, I start having like teenage murder scene bleeding. And I'm like, what the hell is that? So that's my foray into, okay, just because you got treated doesn't mean this is what it is for the next however many years. It constantly is changing. Just like your first pregnancy won't be like your second. Like you have to be ready for change. You can't just be like, yep, check that box, we're done. She gives me an update, all good. We start looking at the blood pressure again. Blood pressure's creeping up. My GP went to med school with my OB, so they're good friends. And basically, she's like, "You can stay on your patch if you take blood pressure medication. If you don't, you can't do that." No cardiovascular symptoms whatsoever. Um, and so that's what we ended up doing. And so I share that to be like, all right, well, I maybe had like a paragraph to study in my board certification for women's health. That's all I had on menopause. And what I learned in just, even like 10 months was so much more. And that made me kind of dive back and be like, what are we missing? Um, and 2 days ago, I think they just removed the black box warning from local topical vaginal estrogen, which has been found safe in all populations because it's local. It can be very beneficial to address genitourinary syndrome of menopause, which can be urgency, frequency, leakage, UTI like symptoms, which can be incredibly helpful for longevity for older women, especially. They're now looking at it in women who are lactating because both are low estrogen states. They also removed the black box warning from estrogen based menopause hormone therapy, which, okay, great. But there's, like you said, there's these bigger conversations, especially in the cancer population and things like that. So the good news is the last couple of years. So as I'm going through this, we're also debunking the WHI from 2000, 2001. My mom went through that. I was not home at the time, but they pulled her off all of her menopause therapy. Apparently it was a shit show, as she tells me now. I wish I'd known then. So all these things are going on simultaneously. Um, and it opens my eyes to all the things that I have not been asking. Um, and then we also have this population who are my vintage that we expect to stay active and we expect to be doing all these things. But now all of a sudden we're having more leakage symptoms because they didn't have pelvic floor PT, 15 years ago, or they want to start lifting heavy. They're told to lift heavy. And what does that actually mean? Do they need to be wearing these stupid weighted vests that don't work? Or should they be lifting up a barbell? Like all that kind of stuff. So I'm really fortunate in that, the Wild West show has kind of paralleled my own personal circumstances. So again, that's very similar to what I've navigated before. And I'm still figuring out my own stuff. But that again, I've got, a stake here. And my friends that I came up with, like I can't go to a swim meet. I can't go to a school event without talking about menopause. Like we just came from the Grand Canyon. Half of the conversation was about peeing, pooping, and menopause. Like, fine, I'm all here for it. So, it's hard because we look back at our moms and understand that there was totally a disservice with what we understand now. But we just have to trust that, we did the best that we could with the information that we had at the time, and we're going to do better moving forward.
Yeah, there's so many interesting considerations and so many question marks because we were looking at hormonal give back with respect to estrogen and progesterone, like almost intervening, so to speak, in that perimenopausal state earlier on rather than later on to get ahead of the
Yeah.
symptoms. But it's like, is this efficacious? Is this not going to cause any undue harm, especially cardiovascular system wise and vascular
Right.
stiffening and that sort of thing? And it's just like, no one knows yet, but hopefully we
Yeah.
are on like the right trajectory because you have the camp of like, oh, exercise is medicine. It's like, yeah, but what if you can't exercise the way that you want to because of
Right.
that first issue, which is
Yeah.
perimenopause?
Right, exactly. No, I mean, it's the which comes first kind of situation. But I think the big difference now is we're having these conversations publicly on social media. All of it, the fact that it is a conversation, and I will say, debunking WHI kind of opened that conversation because for a long time it was like estrogen equals cancer, and so that scares the crap out of people. And so now that we can kind of step away and look at it for what it was, be able to say, okay, for you in front of me, where do we start? Um, it's interesting. I see having a foot in both the pregnancy, postpartum, and the perimenopause, menopause camps. I see a lot of women who are newly postpartum wanting to just like read ahead and be like, okay, well, I'm going to do this for perimenopause. And like you said, we don't have really studies looking at perimenopause. It's mostly postmenopause. We don't know that we can necessarily prevent these things, but we also have to be aware there's a certain population. This is my demographic here that, if they're having kids late 30s, early 40s, it's entirely possible they're going from postpartum right into perimenopause. And a lot of it's like, is it perimenopause? Is it postpartum? Is it the fall of democracy? Like, we really don't know. Like, is it just that I'm a mom with kids? Like, we have no idea. And so you just assume this is going to go on. And so to be able to sit down with someone and delineate, hey, remember those first couple of weeks you were home after you had your baby and you had those night sweats, because that's what happens. Nobody told me that. If that happens again, yes, there's something we can do to treat that. If you notice that you're starting to feel one of the things that they're using almost as a vital sign is people saying, gosh, I don't feel like myself, and for women to feel comfortable vocalizing that to their provider. But it's also a fight to have the provider validate that. And that's a conversation I have with clients regularly where we go through their symptoms. And I'm like, if your physician has 3.5 minutes with you, I need you to emphasize your vasomotor symptoms, because that's what's going to be, typical menopause hormone therapy. The primary indicator for that would be something with vasomotor symptoms. They're not going to give you progesterone just because you can't sleep. There's no primary indication for that, even though it's super helpful. And if you have new onset of leakage or UTI-like symptoms, or you've got vaginal dryness or things like that, emphasize that. That's a separate prescription for local topical vaginal estrogen. So I find myself coaching women a lot to, like, number one, not gaslight themselves and be like, oh, well, this is just this is just that. Like, no, these are all signs. Let's clarify what potentially can be helped with pharmacotherapeutics, what you need to make sure that you don't leave out so that it's not missed, so that you get what you need. And then also understand, and this kind of came from my experience too, just because you start with this doesn't mean this is what this, you may need to have some adjustments and updates as things go along, because perimenopause can be up to 10 years.
Yeah, I have full, like, tipping my cap to everyone who has to go through with this. And I remember seeing it with my mom 15 years ago, and post cancer, and like that's a whole thing of its own with the strokes and survivor guilt, and then the menopause. And as a kid, I didn't know what to do, and she was having a lot of weird this and that, and thank God she's okay
Yeah.
today. But I was like,
Yeah.
how do I play the supportive, loving role when I can't physically do anything to help? And I was
Oh,
end up being 15. I'm like,
yeah.
Mom, I love you, but what do I do?
Oh God. Plus you're a 15-year-old boy, which I have in my house right now. And so expressing feelings are really hard. Yeah. No, I mean, you just love on your mom, I mean, yeah. Well, and here's the thing too, that she's thinking about is, you're going through puberty and she's going through all of this and she wants to be there for you too, but she's having to navigate this. So yeah, that's a whole mom conversation.
Well, I was
But
lucky. I had an older brother, and I was kind of the idiot
okay.
one. And I had a line of disciplinarians between my older brother, my mom, and my grandma. So they're like, Mike, cut it out. And then from there, I was like, all right, I got it.
That's fair. Yeah, that's fair. But no, but I mean, this is the thing that to think about too is like, and it's not lost on me that, my poor husband, he's got a house with a perimenopausal wife and two kids going through puberty. Like, wow, that's fun.
You got to install like a punching bag in the basement. You should be like, all right, go down there for 20 or 30 minutes, get
He's
it
been
out.
working out. He's been working out in the gym, in the garage a lot more lately. I'm not quite sure why, but maybe you're shedding some light on this. But no, but what I will say, this kind of goes back to a lot of the stuff that we're talking about. And initially, I found myself being very adamant about talking to my daughter about this, and I realized I can't leave my son out either. Is to normalize these conversations and normalize, hey, this is what I'm going through right now, and this is what happens with women, and this is what's happening with teenage girls and all of that. And we say the words and we have the conversations and we normalize. I'll talk to my daughter and I'll be like, I'm feeling really shitty today, and this is why, and I'm not mad at you, this is just kind of what I'm feeling, and just wanted you to know that this can happen sometimes too. So I try, and because that was not how I was brought up at all. There were parental conversations and then kid conversations. And so Do they know exactly what I do? No. Although, I mean, they're in my office all the time. There's like, rubber vaginas and things like that all
It's
over the
like from
place. So they
Meet
really
the
get it
Fockers.
now. Right. Yeah.
Barbara
Yeah.
Streisand. Yeah.
Yeah. No. And my poor husband, like, you Google my last name and all that crap comes up. But no, it's one of those things where like trying to normalize as much as possible without over obsessing. They're never going to be embarrassed that their mom's running around in a vagina suit or things like that. Not that there's anything wrong with that. That's just not me. But like, I want them to be okay with, hey, this is what the anatomy is. This is what happens in hormonal things. This is what happens, all of this, and feel that they can come to me with those conversations. So it comes kind of full circle that the more I'm talking to my patients about this stuff, the more I see that it's important to make sure that we're educating the generations that are coming up behind us, so that it's not weird to talk about it.
Absolutely. I want to keep this
Yeah.
going, but I know we have to wrap this up. Where can
Yeah.
people find you and your podcast? This has been brilliant.
Yeah. Oh, thank you. So I try and make it super easy. I'm over on Instagram at Carrie Pagliano. That's also my website, carriepagliano.com. And then our podcast, it went through a little metamorphosis. Initially, it was Active Mom Postpartum, and then crash and burn into Peri. And so now it's just Active Mom Podcast. And so we cover pregnancy, postpartum, perimenopause, menopause. Our guests are a lot of researchers in this space. I talk to clinicians doing some really cool stuff. We talk to everyday moms and athletes doing, amazing things. And the point is to have these conversations so that providers can listen and get perspective. Everyday moms can listen and get inspiration and perspective. And, for all of us to kind of be in that same space, and definitely to elevate the voices of the researchers so they can share their work in their own words. And they have some great stories too and are wonderful people. So just make everybody a little bit more accessible so we can have these conversations.
Awesome. Thank you. Thank you for coming on today, Carrie. This has been great.
Yeah, thanks for having me.